Welcome back. This panel is about what's going on in Michigan with our health information exchanges. We now have 9, and we used to have all of the HIEs in Michigan on the same panel, but 9 is too many. So we had a sort of a lottery, and we have the 4 lucky or unlucky winners of the lottery here today. And I'll introduce them each before they present. But first, we wanted to give just a little more perspective on the network of networks slide that you saw from Tim and Cynthia earlier. You've probably heard us talk about QOs, or qualified organizations, and people have assumed that meant the health information exchanges, but it really means much more than that, and it's a very simple concept. It really just means that an organization has signed the legal documents to be in our legal, security, privacy, and trust framework and can begin engaging in use cases. So there are lots of different types of QOs. They're not just the HIEs, which you see at about 8 o'clock on the diagram. The HIEs are the organizations that connect the providers, the doctors, the health systems, but there are many other types of QOs. Up at about 1 o'clock, you see the payer QOs, and we're at about 20 of those. With the Medicaid rebid, that number is going to increase dramatically. We have 3 additional payers for reviewing the documents to become a QO right now. At 3 o'clock, you have another QO, and that's the Michigan Department of Health and Human Services. Formerly, that was the MDCH Data Hub. But that's how we, using a single secure point of entry, transmit public health reporting into the state's data hub, and the data hub then routes those public health reporting messages to the appropriate registries. If it's an immunization, it goes to MICR. If it's a syndromic message, it goes to the MSSS. If it's a reportable lab, it goes to the disease surveillance system. There are other registries in development for things like chronic diseases, birth defects, cancer notifications. Yesterday, someone talked about possibly an autism registry. So there's also the state's data warehouse, and that's where things like quality measures go. At 6 o'clock, you have the pharmacies. Now, they are not actually QOs, but they are sponsored by a QO, so they can also be a trusted data sharing organization. There are other organizations that are sponsored, such as the U of M Regents and Henry Ford and Alterum Institute. And they participate in various use cases. They've been sponsored by a QO. There's this other type of entity called a consumer qualified organization, and those are organizations that where consumers control their PHI rather than providers. Finally, there are the federal organizations such as the VA and the SSA, and we communicate with those through the eHealth Exchange. So that's just a little tour around the network of networks. So that will help you understand how these HIEs on the panel today fit in to the MiHIN network. So first, I'd like to introduce, going in reverse alphabetical order, a MiHIN board member, John Vismara. John is, on page 35, the president of Ingenium and also the vice president of IT at United Physicians. He has been with United Physicians for the past 14 years, working with the physician leadership and the board of directors to make United Physicians a leading PO with regional and national recognition. John, in addition to his responsibilities with Ingenium and United Physicians, is a member of our board, and prior to joining United Physicians, he worked for St. John Health Systems for 15 years in various capacities, and has served locally on numerous boards, committees, and on the faculty of Oakland University in the Executive MBA program. He received his Bachelor of Science from the University of Michigan, where he was an Evans Scholar and received an MBA. And John, just before you come up, I just want to say that we are so sorry for the past 3 years of your slides being, having glitches. And so your son Jason and I were very concerned about everything working properly today. So we put a test slide up for you. We just wanted to make sure everything was working before you came up.
Well, thank you, Jeff. And as you pointed out, this is often the most exciting moment of the conference for me. What's going to show up when I get started? So I took precautions because I knew my son Jason was involved. Whoops. Keep going, or next deck. See, exciting. There we go again. There we go. So I built some safeguards into this year's deck, and just to make sure that we got the right one going. And I was all proud of myself for building these in, and I was showing one of my colleagues, Wendy, the deck, and she promptly points out, well, you realize it still says 2014 on it. And so, yes, that does beg the question of where the problem really lies. So I'll have to admit to some of that fault. But at any rate, it's always a pleasure to follow Doug Dietzman and hearing about all his millions of messages and apparently now billions of messages. But honestly, I was actually very pleased with the presentations this morning and find myself really building on some of the themes and what they talked about. And I think one of the lines that he mentioned this morning is really appropriate to really where we're at and what Michigan is all about. And I really like that. Common clarity, the ultimate destination. I really think that is super important. And I think if there's one thing that we've all learned in this journey of HIE-ness, is that there's really no one entity that's going to solve this. It's all about collaboration. It's all about working together. And whether we're talking about providers working together to create an HIE or to work between the HIEs or between any of the service vendors, it's all about collaboration. And I think really important in that, it includes the efforts of the state that Cynthia outlined and Lieutenant Governor Kelly, Nick Lyon, but also aligning that with what the payers are doing. And I don't think any of us would be as successful in what we've done without the catalyst that the payers like the Blues have provided and really jump-started and got provider participation in a very positive way. So it truly is all about collaboration. And then for us, it's how do we fit into that? And where do we invest our funds so that we don't have to reinvent the wheel from what Doug or Paula or any of the other HIEs have done? It's all about how do we maximize our investment and then leverage what's already been done. So with that, I'll give you a little bit of background on Ingenium and then talk about where we're focusing and what we've been working on lately. When we started, we're one of the original sub-state HIEs, as Jeff mentioned. Been with MiHIN since its inception, serving on a lot of the committees and the board. But we often say that, we didn't really start out with the purpose of creating an HIE. Back when we were beginning this effort, most of the effort was really hospital focused. And we found ourselves in a position where the doctors that we represented with the other organization that we work with weren't served, and we needed to really make sure that their needs were focused on. So we came at it from a physician perspective. And we've often thought of ourselves as complementary to the other HIEs and really focused on that sharing of information at the point of care from a physician perspective. Now, since then, we've all evolved and we've all morphed and added other services. And we're not the only ones dealing with physicians. There's a lot of others, HIEs, that do that as well. But again, it's all about that collaboration and working together. The services that we provide, we do work with some hospital partners on the public health reporting and then the ADT notification service, more from a sending perspective. And then, of course, we have a lot of effort around the physicians relative to that receipt of the ADT messages. We were one of the original pilots for the ADT notification program. And we built what we call the facility census, which shows all of our providers, which of their patients are admitted to which hospital. And then again, we built on additional services around with a physician portal to help improve communication, a lot of physician interfacing, EMR interfacing, along with data aggregation and reporting to really support the movement towards population health. We have really 3 primary clients. The Detroit Medical Center in Crittenton, where we work very closely with those teams on their public health reporting and ADT services. But our biggest client still remains United Physicians. That was the founding member. And that is a large PO in Southeast Michigan. We have over 900 physicians within that organization connected. We also have a number of what we call institutional data sources, other hospitals, labs, obviously MiHIN, and a number of the health plans where we collect and aggregate data. And that PO services about 1.5 million patients in Southeast Michigan. And so a lot of what we're doing is in the promotion and support of their population health strategy to aggregate the data, ensure sharing of data among the network, as well as performance management and supporting the care management activities. But the last year, our focus hasn't been really on trying to grow and expand the number of clients that we have, but we've really kind of taken a step back and really been focusing on trying to make our service better and try to really improve the use of data and the use of this information. And I think that's been an underpinning of many of the presentations that you've heard so far this year. And there's really 2 main reasons for that. One is what we'll call the balancing act of trying to balance all the different things that we have to do. And this slide could be probably 15 slides when you really think about it, but I just wanted to highlight a couple of things. Like many organizations, we've had to deal with, vendor changes. We deal with a lot of vendors. I think we have I think 238 different parties that we've had to involve to do what we've been doing. That's a lot of different third parties, and each of them are at different levels. It gets to what Doug was talking about, the going house by house, street by street, and trying to do the connectivity. But one of our primary vendors changed their focus during the year last year, and that obviously forced us to reevaluate some of the services that we've been doing. But I think in a positive way, because it's also made us look at other collaborative opportunities and efforts, and we've reached out to some of the other HIEs to see how we can fit in and maybe leverage what they've already done to really build on, to take advantage of that. Clearly, there's lots of regulatory requirements that are taking a lot of resources. Some of you may have heard of ICD-10, but that has certainly been a drag. And then, of course, security. It seems like every day we have another major data breach, and it gets kind of scary when you start listening to and hearing about the organized overseas activities that are going on, even the government-sponsored activities. It does force us to spend a lot of time on security issues. But really where I wanted to spend a little bit more time was on really the use of the data and what we've been doing to help providers at the point of care take advantage of what we can provide them. Because we have been successful, like the other HIEs, in moving messages, moving information, and getting it from point A to point B. And we've got some really good partners like the Detroit Medical Center and Beaumont and the United Physicians that are very interested in working and supporting and promoting this. And so we don't have those barriers of whether they want to participate anymore or not. It's now becoming more about the use of the data. And when you think about it, if we focus on the ADT, we've been doing this for several years now. And we can present ADT messages to doctors all day long. But what was really disappointing to see how many were actually doing anything with it. And so we've been trying to take a step back and find out why not. And when we looked at that, it also becomes very important in preparing for the next generation of use cases, because that whole transportation, the MiHIN distribution methodology, can be used for many, many other data types. So it became real important for us to start to focus on that patient-physician attribution at that individual provider level. And when you think about it, you've got what the practice thinks their attribution is, you've got what the plan thinks their attribution is, you've got what the network thinks their attribution is, and you know what? They're all right to a certain degree, and they're all wrong to a certain degree, but you have to start working through each of those things, and that takes a focused effort. It takes a lot of work, collective work, to be able to get that right. But if you get that right, then that makes the ADT messages that we're delivering that much more valuable and useful. And it also sets us up much better for med reconciliation or discharge summary distribution, that type of thing. And when you also look at that in terms of population health and performance reporting, it's also the foundation for that as well, whether you're talking about a registry where, you know, we're trying to get doctors to go in, manage their panel of patients, pay attention to what their performance is, close the gaps in care. Well, if you've got the wrong set of patients on their reports, or you don't have them focused in the right area, you've lost everything that you've done. So again, it ties very, very tightly into that panel management, making sure you're measuring performance correctly. But it's a lot of effort, a lot of work, and it requires a lot of focused attention. But that also then allows you to work on data capture in the right areas where you have the gaps on the correct patients and the correct patient population. And then when they're looking at their panel, managing their panel, closing gaps in care, we've got a much stronger and more valuable display of information. And I think fundamentally, to get more provider engagement, we need to do a better job at those things. Because as you've heard earlier, it becomes a lot of noise. I think Tim was talking about that. It becomes a lot of noise, and it's hard. It takes more time to sort through it, and I don't have time as a provider to do that. And then, of course, if you have that foundation, that obviously ties into care management activities, makes that a lot easier, as well as supporting communication between the providers when you have a common ground. Because we've had a lot of success at the PO level engagement and activity, but really getting that provider, physician in their office activity, we really needed to spend some time and focus on really that panel management and the patient-physician attribution. And of course, we do all of this in a environment that remains challenging for the physicians in their offices, especially with their workflows and the being bombarded with a number of requirements that they have. Obviously, they want to still work within their EMR, and as was pointed out, a lot of the EMRs aren't real good at accepting this data automatically into the EMR. So there's multiple systems at play here. And then, of course, there's conflicting motivations between meaningful use, the different payer initiatives, or even the network initiatives. Makes it challenging. And I think what's happening, what we have found is that the doctors are looking at each of these things individually. And they're looking at the ROI. Okay, what's the ROI on meaningful use? What's the ROI on payer A's initiative versus payer B's initiative? And they look at it individually, and you get sporadic participation and sporadic success as a result of that. And really the challenge that we've had and where we've started to see some success is when we can bring those things together and show them it's a common ROI, and that this methodology and these programs permeate across multiple programs. And when you look at that common ROI, then we've been getting much better adoption. So with that, I'll thank you and turn it over to the next lucky speaker.
Thank you, John. So next we'll hear from Paula Hedlund, who's the Chief Innovation Officer for the Upper Peninsula HIE. Paula, in 1998, at the inception of Upper Peninsula Health Plan and Upper Peninsula Healthcare Systems, has been responsible for implementing the IT infrastructure for those organizations across the UP. In 2010, she took on the role of regional coordinator for UP-wide HIT, and additional responsibilities have been overseeing the Regional Extension Center in the UP and the development and implementation of HIE. So Paula has a bachelor's degree in Computer and Network Systems Administration from Michigan Technological University, and is also a 2009 graduate of the Lake Superior Leadership Academy. Paula, welcome.
Thank you very much. This one here. So first, I just kind of wanted to, I guess, echo the same thing that everyone has kind of been talking about. We've all kind of been through this together over the last, 5 to 7 years. And so I think we've all sort of learned from each other. I think a lot of what we're all doing is kind of the same thing, just, different with respect to whatever areas that we operate our businesses in. So in the UP, I think kind of as Jeff mentioned, I wear a lot of hats in the UP. And I think while that can be overwhelming sometimes, it's also very beneficial because it gives us an opportunity to understand several different things going on and how things overlap. So what we try to do is, when we go into a facility or a provider office or, we're partnering with the health plan, we're always trying to sort of leverage what already exists and trying to figure out how can we take 3 different requirements, let's say maybe with our PO or our PGIP programs or our health plan with the integrated care bridge record that we're required to do on the dual side. How can we kind of leverage all of those things and distill it down into one vision of how do we make this thing happen? So I think we've been pretty successful with that. I think, and others have echoed sort of, when I started this in 2012, I had this real pie-eyed view that, we'd have all these providers connected, we'd know where patients were going, we'd have all these, provider notes, and people would be going into the portal and seeing that they're seeing 3 different PCPs and all the facility information. And after about a year, I realized that was not going to happen, but there are some really great things happening. So I think we had a really good vision when we decided, in the UP, we need a community-wide virtual health record. I think that's been very, very important. We've been able to capitalize on the whole meaningful use requirements by getting the facilities to submit their ADTs, their lab, radiology, I think, which, is a really important underpinning for getting providers to start to connect to HIE to look up information. We have participation from all 14 facilities in the UP. We have 85 plus provider clinics. Now, the clinics aren't using it yet. We have many clinics that are, but I think we're still trying to rein in that focus of how do you get the PCPs and specialists engaged in HIE. And so, we have a vision for that, and I'll kind of go through later a couple of things we're doing to get more providers on board. We've partnered with the local PIHP. We've had a lot of discussions. We're kind of limited by the whole consent issue. I won't lie, that's a tough issue to get through, but we're both, on both sides, on the PHP side and the health plan side, we're working really hard to come to an understanding on how we can make that work. And I think we have a pretty good plan set forth with the duals, and then that can extend really throughout any population in the UP. So it's not limited to our duals demonstration, but certainly, the HIE work that we're doing in the UP is going to be an important piece for allowing that to happen. We're starting to work with long-term care agencies and then home health and hospice. So really our focus is to start to reach out to those ancillary type providers who, they didn't get meaningful use money. They may or may not have an electronic EHR, but they're obviously very important sources of information that providers and the health plan wouldn't ordinarily have access to. And so we've kind of, retooled our vision to say, how do we get other types of entities that, traditionally aren't participating? What kind of services can we put out there to get them engaged? And then the health plan support for both the integrated care bridge record, getting data flowing between the health plan and the integrated care teams. That's a really, really important piece, obviously. And again, the vision of the UP is to move beyond the dual space and really start to figure out how can we partner with other payers, not only Blue Cross, but there's a large Humana population. We're working with Consumers Mutual with their population. So, in a 2-year period, I think we really hope to be able to reach 2/3 of the payer population in the UP, and that's pretty huge compared to, where we were just a couple of years ago with, our small Medicaid population. I guess this kind of just, gives an overview of what the virtual health record looks like. As I said, our hospitals are, we're between the value-based contracts with Blue Cross and the meaningful use. I think they're starting to see, where the importance is for them to participate. We, take the use cases that MiHIN has brought forth, and we always bring those back. And, sometimes those are a tough sell. So we've had hospitals interested, let's say, in doing the, participating in the newborn notification use case, and then they go back to their vendor and realize it's going to cost a small 25-bed hospital $10,000 for the interface, and then they're like, well, we pay somebody to do that already, so maybe we can't participate in that. So I think, some of the awesome and cool, innovative use cases that MiHIN's coming up with, I'm really happy that some of the larger HIEs are able to participate in that. And I think our challenge is, how do we leverage these critical access hospitals and smaller hospitals? How can we sort of leverage the work that the other HIEs are doing to get those same use cases into our facilities? So from a statewide perspective, we are providing both the submission and delivery of the statewide ADT notification service. And we also do the public health reporting use cases for any of the facilities in the UP. We have a couple of facilities participating and a couple of POs participating in the delivery, and then we offer direct. So one of the things we kicked off last year was our Smart Alerts ADT delivery service. So we partnered with our vendor and with the Upper Peninsula Health Plan to kind of take a stab at this. So we started with one 25-bed hospital. We turned it on, and there was like 80 ADT messages from this tiny hospital to our case managers, and they said, shut this thing off. So we were like, okay, let's go back to the drawing board. So, kind of over a year, we got really, really good at kind of figuring out how to make these useful. And so I think with the work that we've done with the health plan, I think it's really poised us to assist providers in the Upper Peninsula on, sort of the meaningful use of ADTs. And so, we have 7 facilities locally in the UP that information goes through HIE, and then the ADTs route through our Smart Alert system. And so we have our local ACRES file from our health plan, and we have providers participating. But there was still so much, that the case managers were just like, this is insane. I don't know what you expect me to do with all of these. So we kind of broke it up into different buckets. And so if one of our health plan members has an assigned case manager, they'll get what we call a directed alert. So that alert will go directly to the case manager because they're assigned to that patient. And so we could also do that, let's say, in a PCP office. And if we have like our Medicaid members who they're not in chronic case management, but we still want to know what's going on with them, those messages were going in a daily digest, and then the care managers or one of our utilization managers could kind of review that daily digest just to make sure that nothing got missed. And so we kind of took a step back and decided that we really needed to do some more work on filtering and refining those messages going into the daily digest. So our next initiative that we're working on right now is taking a risk score. We could use various risk scores. You could use their Medicare risk score. We have a symmetry grouper internally, and then we also have the CDPS plus. So, a separate project the health plan is doing is sort of trying to figure out which risk score is right, because each risk score is going to be a little bit different. So, that's a whole nother topic. But I think if we can get to a risk score that we're happy with, then we can put that risk score on our member level file. And then we can filter out more of the directed alerts where, there's really something going on with this person, or they have a low risk score, but it's a really high, a high value alert, either in a diagnosis or, something major going on with somebody that you wouldn't have ordinarily thought was risky, or vice versa. You have high-risk patients that maybe, they fell off the radar and you really want somebody to look at it. So that's kind of the next thing that we're working on, and then being able to deliver those out to the primary care providers. And so we're working with a couple of offices right now, and I know sort of some of the initiatives say that you take your whole patient panel, you get all the alerts, and you do something with it. What we're trying to do is kind of try to take a step back with providers and saying, you know who your top 50 or 100 patients are. Let's just start with those. Just start with like 50 people. Do something with every alert, at least look at it and have workflow, that kind of matches what's going on with those patients. And then you can kind of, add different patient profiles as you go along. So I think taking that baby step approach and sort of starting slowly and allowing the providers to go at their own pace, I think has been very successful, and we're just at the beginning stages of it with, you know, some provider offices that are very open to working with us. So I think, you know, we'll have to continue to refine our strategy for providers maybe that aren't so willing to have some office disruption and, you know, really look at things from a different perspective. But we're pretty excited about really, you know, being able to do the ADT alerting, not only with PCPs, but, you know, there's obviously value in sending that information to, you know, long-term care agencies, as was mentioned before, to the PIHPs for their patient population, so everyone kind of knows what's going on. And then the latest thing we've been working on, we received a local grant to connect 23 long-term care agencies. And so there's really two pieces to this. So there's benefits to the agencies, and then there's benefits to other HIE participants. So from the long-term care agency perspective, you know, their highest need really is being able to see lab results from the facilities. So for the 7 facilities that we have connected right now, 4 of them are providing lab results. So really we'll reach out for our initial pilot group, reach out to those long-term care agencies where the facilities are submitting lab and radiology results. And obviously, you know, the 7 are already doing the ADTs. You know, they're mostly paper. Some have EHRs, but generally speaking, they're pretty much used to faxing everything everywhere. And so if we can give them a direct message and start to, you know, connect the UP, all of the providers with direct, I think there's a huge opportunity. You don't even have to start getting into query-based exchange with XCA or XCS.B. I mean, you can just do it direct. There's a lot of value in just attaching a document or attaching a CCD to a direct message and sending it to somebody. So I think, you know, again, the idea of starting small and getting some successes and then kind of building on from there. And then from sort of the other HIE participants, another piece of this is taking the MDS reporting and translating that into a CCD document, which is available in a repository and is queryable. So this is not something, you know, we made up. Our vendor has another HIE. It's the Central Illinois HIE. They went off of some work done by a Beacon Community HIE. So, you know, we talked to this organization, and we knew that the duals demonstration project was coming up, and we thought this was going to be really, really important. I don't know that there's a whole lot of use outside in the PCP community seeing the MDS, but I can 100% guarantee you that the health plan would love to get these reports. And so, you know, I think the next step beyond just getting the MDS translated into a CCD document, it's queryable within the HIE portal. Wouldn't it be great if we could get an alert sent to the care manager when a new MDS report came up for one of their patients? So that's something, you know, that we're working towards. So that's all I have.
So, thank you, Paula. Next, we have Jay Desai. Jay is the founder and chief executive officer of Patient Ping, and I'm going to let you know, let Jay tell you what they do next. He is also, they are our newest HIEQO in Michigan, and prior to founding Patient Ping, Jay helped lead the Accountable Care Organization model development at the Center for Medicare and Medicaid Innovation. And he also supported the development of bundled payments, medical homes, and a variety of other new payment models funded by the Affordable Care Act. Jay's prior experience also includes Triad Isotopes, Parthenon Capital, and Lehman Brothers. Additionally, he served as a subject matter expert on health reform and helped co-found the Health System Transformation Task Force. Jay received his MBA in Healthcare Management from the Wharton School and his BBA from the University of Michigan. I wish we had that test slide queued up for you, Jay. So welcome.
Thank you, Jeff. So before I start, I want to just offer my gratitude for everything that's happening in the state of Michigan. And this isn't just lip service. This is really sincere in that what's happening in this state is very unique. It's very special. And We are operating in other states, and we could not do what we're doing without the work of folks like Great Lakes and Ingenium and HIE and the other HIEQOs here, MiHIN, especially. It's been really an extraordinary partnership, and we feel very grateful to be participating in this environment, and we don't take that privilege lightly. So I'm going to offer you some information here on why we're doing what we're doing, and then that'll flow into what we're doing. So there's a few points that I'm going to make that I'm sure you guys have heard over again over the course of the last 2 days. But I appreciate you bearing with me. I'm sure I'm not going to be able to make the same points as eloquently, but I think they're important. So the issue that we all know about is that patients receive health care from a lot of different providers. Ambulatory, acute, post-acute, they're highly siloed entities. Patients go to a lot of places, and I'm going to illustrate that with an example of my mother. So I was really excited to find that Michigan hat picture last night, and Jeff was kind enough to swap it out last night. I was like, it's an important reason. We need to do it. My mom, about 3 months ago, had a total knee replacement done. And, she, very standard procedure, elective procedure. She's about 68. We're from Illinois, from Wheaton, Illinois. She went up to a surgeon at a hospital in the North Shore. Perfectly fine. The procedure went very well. Went to a skilled nursing facility for rehab. Was there for 3 weeks nearby our house so that my dad could go see her. Went home after 3 weeks. Got home help 1 day a week. And unfortunately, in the second week, she tripped on a rug at home and went back to the emergency room. It was fine. She had a fractured shoulder, and she's recovered now. Over that episode, she saw about 15 different providers, and there were a lot of opportunities over the course of that care for her to receive more optimal care. So, for instance, she didn't know that home health was available for her while she was in the SNF. So she was there for 3 weeks. She probably could have gone home faster. When she was at home, she tripped on a rug, and that was because she was wobbling, and she's stubborn, which I love her very much, but she is stubborn and probably wasn't using the cane. Tripped on the rug and then went back to the emergency room. I know that there's a lot of home health workups that look at fall risk, for instance, to be able to avoid that sort of thing from happening. I think centrally what broke down was that there was a lack of communication between the providers that were all delivering care for my mother. So what I'm going to, we've heard this, value-based reimbursement is shifting how providers are practicing medicine. I think the point, though, that oftentimes goes understated is that there is a new workforce that's being formed. We used to use the word case manager around the HMO managed care time. Now they're called care coordinators. And so when we ask the question of who's going to do the work with the information that Health Information Exchange is facilitating, that's the answer. It's this new crop of providers who are getting into the business to coordinate care across all these different facilities. And then you layer on top of that some of the incentive models to encourage the existing healthcare ecosystem, the healthcare provider ecosystem to do the work. And primary care now is getting into that work. So whatever you call it, whether it's a hospital readmission penalty or a value-based reimbursement program like PCHIP or advanced primary care demonstration like MIPCT, or ACO or bundled payments, it's providers that didn't exist before, or they're sort of equipping themselves with new capabilities to care about what's happening outside of their four walls. So when we think about use cases and how to get providers and how to get health information into the workflow, that's why we do what we do. It's really about trying to leverage this new sort of crop of providers and new capabilities that providers are investing in to work together. And so our mission, what we do, why we do what we do, is really about allowing all providers to share patients to work together. So how we do that, simplicity is paramount to our approach. And we think that, you know, for workflows to actually change, they have to be simple. The technology to enable it has to be really simple. And so our services are pings and point of care guidelines. Pings are what we call the ADT notifications. So it's real-time notifications when patients are admitted or discharged anywhere. And then we also think that data shouldn't just flow one way, and this is not just us that thinks this. It's, you know, if I'm a PCP and a patient shows up at the emergency room, well, I'm getting a notification, but we want that emergency room to know that I'm getting the notification, that I'm on the other end of it. And so that's what we call the point of care guidelines. And again, we could not have done this without MiHIN. The data that we get from, you know, to provide these notifications, we know comes from the sending QOs. It's a really extraordinary thing to have all these different groups working together, and we're excited to be able to soon provide the data that we get from other entities that we're going to be working with in the post-acute care universe for the other QOs. So it's just it's really cool what's happening here in the state, and we think that really big things can happen if you can wrap around very simple workflow solutions. So how does it work? Patient arrives at the admitting site. We get that data through MiHIN on the hospital side, and then the admitting provider gets the care guideline, the PO receives the ping, and then it's routed to wherever it needs to go. And it's, you know, it's a really straightforward, pretty simple service. So, you know, our vision really is about connecting providers all across the board, wherever they go. And we think these ADTs are a really lightweight way to facilitate some of those that connectivity. And, you know, sort of to wrap up, we do feel just honored to be part of this community in Michigan. And the amount of progress that we've been able to make in partnership with the other entities here has been dramatically accelerated when we compare ourselves to other states because of the work that's happening here. So thank you.
Thank you, Jay. So batting cleanup from Great Lakes Health Connect is George Bosniak. George is the Director of Business Development for Great Lakes Health Connect, which he's helped grow since he joined there in 2011 to its current position as one of the nation's most successful HIEs and certainly the largest in Michigan. George oversees their statewide business development and contracting negotiations, as well as marketing and communications. Prior to joining Great Lakes Health Connect, George served as the business development manager for the Right Place in Grand Rapids and as the executive director for the Grand Haven Main Street Downtown Development Authority. George has a bachelor's degree in economics and a master's degree in public administration and urban and regional planning and policy from Grand Valley State University. Outside of work, George donates his time as council president of Bethlehem Lutheran Church and vice president of the Grand Valley State University School of Public Health and Nonprofit Administration Alumni Association. That's a lot of outside donation. George, welcome.
Great, Jeff. Thank you for the kind introduction, and Tim, thank you earlier for your kind words for Great Lakes Health Connect and what we've done. So, quickly, as you heard earlier, Doug got a chance to quickly explain. Great Lakes Health Connect was formed July 1st of 2014 as a merger of two former HIEs, Great Lakes Health Information Exchange and Michigan Health Connect. Great thing about both those organizations coming together was the common vision, mission, and what we are looking to accomplish. And I think you heard a little bit of that today from the other panelists up here and a lot of the other HIEs that work with across the state. But there's our mission and vision. Everybody's got one. But really the bottom line goal is what we're here to do is to be able to provide the best, most accurate, real-time patient information at the point of care to provide the best information that those caregivers can make sure that they're making decisions based on information in real time and that's accurate and from across the care continuum all across the state. So our coverage, you got to see this earlier, 126 hospitals, 82% of the acute care beds, really spanning organizations in every county of the Lower Peninsula. We also connect over 3,000 organizations. So those can range anything from a PO to a payer to county health department to food banks to the largest health systems. So we're luckily and blessed enough with our business development team and the individuals that are working across the state to find ways that individuals are touching a patient health care that we can connect and we can help in many different ways. The statewide master person index also that spoke about a little earlier, the longitudinal patient record, today is being contributed by over 50 facilities all across the state, representing over 6 million unique patient records for a state of Michigan. So you can kind of figure and do the math in your head. Michigan has about 9 million citizens. If you cover over 66% of that, you're getting a pretty good chunk of the patient population that has a central area where anyone inside the network can reach and touch and pull that information up in a view. Our partnerships, a lot of individuals and earlier today and through here have talked about their partnerships and what they're doing with each other and with MiHIN. So this is just a list of kind of the primary ADT lab immunization syndromic reporting totals by month that we're sending up to the state of Michigan. And you can see by the numbers on the left there, that's a lot of zeros. So those are a lot of connections that we've been able to build in a lot of ADT and immunization messages. What's been key to that is finding a way that we can make this scalable across a state where there are thousands of providers, hundreds and hundreds of hospitals, and a growing number of care coordinators and other individuals that need to be able to provide and send this information. For these 3 or 4 solutions, we've been able to do that and been able to provide that up to the state of Michigan to help make all these other programs successful. So across, what do we believe as an HIE is? What do we do? What can we provide to those out in the community? And this is just a quick overview, and I'll dive into each of these a little more, but you need to be able to connect point to point, doc to doc. We need to be able to exchange. How do we send from one to many, from that inpatient to the ambulatory setting? Notify, how do we be able to give those real-time notifications of event occurrence? Focus, how do you dive in and be able to pull that information from a variety of contributing sources all across the state and see that one longitudinal patient record? Engage, how do we be able to help our members provide information for their patients? How do we help our payers be able to show that longitudinal patient record? How do we be able to support those patient portals that everyone's being required to put together? And the final is explore and analyze, and that's that forward-looking vision. We talked earlier about big data yesterday, and Tim talked about, we have this plethora of data, and we've shown you the billion messages and the hundreds of millions that we send every month. So how do we leverage that, and how do we start using that to dive deeper and ask some pretty critical questions? And that's the final step. So Connect, we have a tool that's foundationally put together is referrals. How do we be able to exchange an electronic referral that's fully HIPAA compliant, where an individual can be sent to another provider, primary care to specialist to Children's Hospital, all across the state. We've got about 950 individual organizations that are sending over 20,000 unique patients every month from location to location. Direct HISP, we talked earlier about how do we get those CCD messages out from EMRs, and the ability that's lacking is how do they receive or how do they catch those CCD direct messages, and we have the ability to provide an inbox and set those up for the provider community all across the state and set up those direct addresses. Exchange, so kind of core foundational to a health information exchange is how do we deliver all of those lab-read ADT transcribed document reports out of that inpatient setting into a provider setting or a care setting or a PO setting that's how they want to consume it. So whether that's as a discrete message inside of an EMR, or that we provide an inbox for those paper-based practices that we can send to there, or that we send it to a registry for a PO so that they can provide that information out to their community, or do we put that inside of that longitudinal patient record that can be queried and viewed all across the state? So multiple different ways that we're delivering those messages and making it available for all people in the care continuum across the state. The state submissions, we're lucky to be able to have worked and done so many immunizations, reportable lab syndromic, the birth defect registry, which is we're working on, and then the immunization microquery. So we're committed to, as those use cases come out of the state, and our members across the state need to meet those standards and meet those requirements, that we'll find a way to be able to provide that. So also very interested to hear Paula and how we may be able to help some of those communities up there and make that an affordable solution across the state for what we've learned in implementing those in the use cases. Imaging solutions, so how do we provide those radiology reports in a zero footprint viewer as we deliver those results out so that individuals can stay inside of their receiving EMR and other systems or that community view and be able to look at those images remotely. Notify, and you've heard a lot about ADT notifications, and Jay, who came out just before me, has a unique tool of delivering that. We also deliver ADT notifications using the statewide service. We have an ability to deliver that based on provider code, based on delivering it directly into an EMR, into an inbox, or into some of the registries. So we have made multiple use cases and had to meet individuals across the state where they are, and how do we get that information to them in a usable fashion that they're looking to receive. All of those are available, like I said, either through the state submission or directly through our process of delivering that. So focus, that's our virtual integrated patient record, and as I stated earlier, we've got about 50 inpatient organizations today that are contributing those lab, radiology, ADT, and transcribed documents, making up over 6 million unique patients across the state with multiple times that pieces of information, results, lab reports. So a really great, robust data source that we're making available either through a portal view, through a connection to an EMR all across the state at the inpatient, at the ambulatory, at the PO level, and at the payer level to be able to, like I said, provide that most recent up-to-date information for patient care. Advanced care document services, so we have an ability, and we are doing this today with multiple organizations all across the state, to be able to contribute those advanced care documents to that longitudinal patient record. So anywhere that individual shows up across the state, whether it's Munson or St. John's or Beaumont, that those individuals would be able to have that advanced care document follow with them. So it doesn't have to be, on the refrigerator, in the glove box, depending where an individual has care. It follows them electronically and follows them in this record. That goes along with asthma action plans that we're beginning to post to each individual, and also care plans for those super utilizers and heavy utilizers of an emergency department. How do we have those care plans that an emergency individual can see and follow that plan for unique individuals that need special treatment? Engage, direct HIS portal support and patient portals. Great Lakes Health Connect does not provide a patient portal. We do that intentionally as that we have providers and payers and hospitals that are members that are all being required to provide a patient portal, and all have a percentage of their patients that they need to be directed to those portals. If we were to create another portal, then we would be directly competing with them and having the ability to get that number of patients to see their portal. So what have we decided to support on that? How do we provide the information that we're gathering across the community and be able to provide it to those patient portals? And we're beginning projects today of how we support back-end individual patient portals for our members with that larger data set that we're collecting from across the state. And explore, operational analytics and community analytics. The longitudinal patient record does have a great deal of information, and we're working with POs and other individuals to meet their HIEs standards, their Blue Cross requirements, other reporting standards that we're looking to do. We also work with special community organizations that are taking responsibility for a specific patient population that need information on unique geographies or unique treatments, that because we have that database that our members have contributed and supported, that we can be able to provide those informations for those results going forward. So that's really the end of my presentation. I want to thank everyone for being here and thank our peers for coming up. I think we have some Q&A time. Yeah. Great. Thank you all.
Thank you, George. I have to say, I just have the best panelists because they always end on time. So we have time for some questions here, right here. And I saw the first hand here, and there must be, we've got questions all over the place. So we'll start here. George, right here. Do you have a mic? Okay, let's borrow one. Let's go ahead and start with one back there if we have a mic back there. Let's get that one going.
Hi, yes. I have a question directed towards Jay and George regarding your alerts and pings. Have you guys had any challenges regarding any academic settings where there might be residents in clinics, and who are you notifying, either the attending or the resident physician?
We're having trouble hearing your question. Could you please help us with that?
My question is for Jay and George regarding your alerts and pings for ADT notifications. Have you had any challenges regarding academic settings where there might be residents in clinic, and how to identify who to notify, whether it's the attending or the resident physician?
Well, can you hear me? Yeah, okay. We found that it's largely who's receiving the notification is very much a function of the workflows and how they're designed. So we, right now, the consumers of the pings in our universe are primarily physician organizations and ACOs who are routing the notifications to the practices or to the care coordinators at a sort of an administrative level. Or some people are setting up different triaging functions to create cases for folks to do the care coordination on. We don't have any groups right now that are routing the notifications to the clinicians at the AMC yet, but we've had some discussions with some who do want it to go either to mostly what we've seen is folks want it to go to the hospital social worker, not necessarily to the attending or the resident at the hospital, but I could see it being valuable there because I know that's a lot of work. My girlfriend's a resident. I know she does a lot on that, and she feels like it spends a lot of time on that.
So specific to your question, no, I don't have an exact use case for that, but we do deliver ADT messages to docs and other settings, and really the challenge is if they're not on the message as a primary or referring physician or any other identifier with that ADT, and they don't have an ACRES identifier, it's nearly impossible if we don't have some sort of information in a message to be able to deliver it to the proper location. So if there is an identifier for an individual or matching at a state level or distribution service we can run through, technically there's no issue in being able to deliver that message to any location. It's just having those correct identifiers for the endpoints that's a challenge.
George mentioned something very important. He mentioned the ACRES identifier, and earlier you saw Dr. Tim Pletcher show the ACRES slide. If the physician has declared an active care relationship with that patient, then they will receive a copy of the ADT. So if you're a complex chronic condition patient with 9 people on your active care team, all 9 will receive a copy of that ADT.
If I can add a couple comments, because when I talked about the patient-physician attribution, we actually are working with a couple of residency clinics, and that is a very big challenge. I wish I could say that we successfully have solved it, but it does boil down to how the clinic wants to attribute patients. Do they want to attribute it to the residents, or do they want to attribute it to the primary care doctor, or both? And so the first step is to make sure that the clinic knows how they want to be notified, to Jay's point about workflow. And then secondly, can the hospital support that in defining their attribution?
That was a great question. We have time for one more here.
I'm Marcia Mangold. I'm with Blue Cross Blue Shield of Michigan, Information Security. And I had a question about when you were developing these solutions and as you go through, are you looking at how it can help with fraud and other things that are happening? Because all I'm hearing is about the patient and the hospital. But as I'm listening, I'm hearing how if you have all this information being exchanged, if someone is getting health care in, say, Detroit, and all of a sudden you see health care in Upper Peninsula, and it's for something that's slightly different, are there any alerts or anything that's built in that are sending back that type of information so that we can help to make sure that the record information is correct and that there isn't fraud and other things occurring within your system?
Yeah, that sounds like a great use case that I'd be happy to talk to you right after this about.
We have started in our medications use cases. one that has to do with monitoring controlled substances, which is obviously a large source of that type of fraud with drug seekers. And so there are many different types of fraud, but the early conceptualization of that type of use case is underway. So thank you. Okay, out of respect for Dr. Friedman, please stay in your seats. You're going to hear about the learning health system next. Thank you very much. Let's give it up for the HIE QOs.